So good afternoon, everyone. My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And our Learn and Share conference call today is on epilepsy self-management, and we're very happy to have with us Dr. Toya Malone, who is an epileptologist with Bronson Neuroscience Center in Kalamazoo. And we're very happy to have you with us. Can you give us a brief overview of your clinical and research interests and then also your experience with this topic?
Sure, no problem, Russ. So I'm out here in Kalamazoo, Michigan. I have a practice of adult patients primarily, but I do see some pediatric patients down to about age 12, and I probably see about 95% epilepsy. Occasionally there's some other neurologic disorders that are thrown in, but primarily epilepsy. In terms of experience with this topic, I believe epilepsy self-management is something that is probably discussed with every patient at every visit to some extent. So a lot of the different topics that we'll touch on today are things that, on a routine basis we discuss in the office to help patients manage their seizures.
Great. So as the title suggests, today we're going to talk about epilepsy self-management, and that really refers to everything a person with epilepsy can do to positively impact their seizure control, their health, and their well-being. So we're really talking about behaviors here. In some cases, effective self-management requires changing unhealthy behaviors or adopting new behaviors, and that can be challenging. So on this call, we'll first talk about some of the behaviors that are most likely to impact seizure control, and then we'll talk as a group about some of the challenges associated with behavior change and then how to overcome these challenges. So let's start by discussing medication management. So typically the neurologist will prescribe one or more medications for epilepsy and maybe for other conditions as well. But it's really the patient's responsibility to take the medications as prescribed, and the patient also needs to keep track of possible side effects, to tell the neurologist about any other medications that are being taken, to respond appropriately if a dose is missed, and make sure that all the prescriptions are refilled on time. So can you talk more about why these behaviors are important and then how people with epilepsy can be successful in managing their medication?
Sure, Russ. So to start, it's really important for patients to be honest about how often they miss medication doses, because for us as neurologists, epileptologists, we want our patients to be seizure-free. And by having breakthrough seizures, if a patient misses a medication, if they don't let us know, we may make the assumption that the medication isn't working at a sufficient dose. Therefore, we would want to increase the dose and or add a different medication. If the reason that the seizure occurred is because a missed dose of medication occurred, the chances that the medication is actually working when the patient takes it is very high. Therefore, we wouldn't make any medication changes, but just talk about better ways to be compliant with medication.
Right.
So I guess the bottom line is we just don't want to assume that the reason that you're having more seizures is because the medication isn't working, but it's in fact because you're missing medication, and then we can just sort of talk about ways to help you out with that.
Right. Okay. And so what are some other things in terms of just general habits in terms of taking medications that are important? Things like telling, like in terms of other medications that are being taken, why is it important to share that information with the neurologist?
There are some medications that we prescribe, and sometimes other doctors prescribe, that can interact with seizure medications. Mm-hmm. Those can lead to additional side effects from medications, and in some cases, breakthrough seizures. I think we'll talk about that a little bit later, but there are a list of medications that could potentially cause seizures. Right. There are ways, I know it can be difficult to take medications and be compliant when there's multiple times per day a medication has to be taken as well. And when that happens, usually we counsel patients to either have a pill box, which is a really good idea, to help separate out the doses and be sure that you take the doses when you're supposed to. I have patients that also set an alarm on their smartphone or watch or whatever, and that helps remind them when they're supposed to take medications. Mm-hmm. In terms of the other medication interactions, as I mentioned before, our biggest goal is to have seizure control without medication side effects. So by knowing exactly what our patients are taking, what they're not taking, and being aware of the interactions that are possible, we'll be able to best help treat that patient and have as little problems as possible.
Right, right. And have you had any patients? I've heard other people talk about sometimes the pharmacy will actually put, if they have multiple medications, will actually put them in those, I forget what they're even called. They're the sealed packages where they're divvied up by day, and you have all the medications in one sealed or blister pack, I guess that's the term for it. Have you heard of people using that effectively as a way to organize and remember to take their medications?
Definitely. I'm not sure about the retail pharmacies, but I know several of my group home patients, when they get their medications, they do come specifically separated out into medication doses. They call them bubble packs where I am, but they come in these blister packs or bubble packs, and each medication dose is separated out so that it makes medication administration a lot easier. It also makes it easier to keep track of what you've actually taken, what you haven't taken. And with epilepsy, sometimes as a result of seizures, other times as a result of the medications, patients with epilepsy tend to have a lot of difficulty with memory. That's one of our probably most common complaints.
Yeah.
Therefore, that can also impact your ability to keep up with medications. If there's any confusion regarding medication dosing, regarding whether or not you took your medications, a lot of these different systems can be helpful. And then also having a support person, someone that can be there to help actually separate out the medication for you or even administer the medication. All of those things are really helpful when it comes to administering medications on time.
Right, right. And in terms of getting prescriptions refilled on time, do you find that is sometimes a problem where people will forget that they notice, oh, I'm down to one pill left and I haven't called in my refill? I mean, how do you avoid that, I guess?
That is a very big problem. I can't say that all patients do, but it does happen typically on a Friday afternoon as we're about to close the office, which can be one of the most dangerous times to have to call in for medication, hoping that, you catch someone or that people aren't on vacation. The issue with missing medications is also that you risk having breakthrough seizures and or what we call status epilepticus, or recurrent seizures that don't stop by themselves. Sometimes those require treatment here in the ER and or ICU in order to stop the seizures. So to avoid any of those problems, I try to refill the medications at the office visit even prior to the last refill. Sure. A lot of our patients here, we're on EMR, Epic here, and they'll either send a request via Epic or sometimes they'll call into the office. There are some pharmacies that automatically generate a refill request for our office. I believe that probably happens more so with the group home residents and then also mail order companies. But waiting until the last minute puts you in a very precarious situation because you do run the risk of either not being able to get in touch with the office because it may be close to after hours. Yeah. The pharmacy may close and you may not be able to obtain your medication. Out here in Kalamazoo, there are some medications that have to be ordered in from outside pharmacies. So your pharmacy may not have the medication in stock. Therefore, you may have to wait a few days before getting the medication. Or the provider may be on vacation. If that's the case, you may run the risk of, maybe someone in the office having to scramble to find someone else to fill your prescription. Hopefully it gets filled correctly. We tend to do a pretty good job covering each other, but anytime you shift care to someone else, there's a chance that there could be a mistake made. Right. So making sure that, I would say probably by the time you get down to maybe a third of the bottle, or if you're taking a medication once a day, 10 pills or 10 days worth of medication, you should definitely be sure that your next refill is on its way. Right. That'll help ensure that you don't run out of medication before the next refill comes in.
Right, right. Okay, so in terms of epilepsy and side effects, or the medication side effects, because epilepsy itself or the underlying brain condition that's causing it can be responsible for a variety of symptoms other than just seizures. You can have depression, sleep disruption, memory problems, all related to the epilepsy and not necessarily the side effects. How can people with epilepsy tell which symptoms are medication side effects and which are not? Because obviously they want to report any possible side effects to the neurologist.
Right, and all of our seizure medications do come with side effects. The side effects that we see are typically side effects that happen when the medication is started, as the medication dose is adjusted, and then if we reach a dose that's too high. Typically, side effects last anywhere from a couple of days to maybe even a week or so. After that, side effects typically start to resolve or at least diminish in intensity, so they should get better. Symptoms that don't get better and that are persistent are symptoms that we need to know about. Anything that may be medication-related, of course, that's going to prompt your provider to maybe change your medication, especially if it's a side effect that interferes with your daily functioning. We don't want you to be sedated or cognitively not able to perform any task that you need to perform while you're on medication. You should be able to function at your peak, at your optimal level. And if that's not happening, we need to make some changes. Anything that persists beyond, like I mentioned, those sort of 3 intervals when we start medication as we make increases, and if the dose is too high, that may indicate that there may be something else going on. Patients with epilepsy do have a higher tendency to have other conditions, like you mentioned, Russ, with problems with depression. Sometimes there are sleep problems, and then there are also memory problems that can happen. And when that's the case, we want to identify those and maybe treat those separately. Right. So medication side effects should be more short-lived. They should happen more so right after you take a dose of medication. So within an hour or so of taking medication, that's typically when medication side effects present. As the course of the day goes on, those side effects tend to diminish, and then they may increase again when you take your next dose of medication, if it's a twice-a-day medication, or the next day if it's a once-a-day medication. But either way, there's a cyclical pattern that we see when it's medication side effect, as opposed to a constant level, consistent level of symptoms that may indicate that there's something else going on that may not be medication-related.
Right. Do you think in general that patients maybe overestimate medication side effects, or tend to attribute any symptoms that they have to medication side effects? I've kind of noticed that sometimes that
can happen.
Yeah. Okay.
Yeah, that can happen where sometimes there is. I don't really want to call it over-reporting, but sometimes there are more side effects than we anticipate that may occur with the medication. When that happens, again, I encourage all of our patients to talk to their provider, only because we will be able to differentiate what may be a medication side effect versus what may be something else going on that may be in the background, maybe something that wasn't noticed may not have been as obvious before the medication was started, and now patients are paying more attention to things, maybe it seems to be more apparent. Other times our medications can exacerbate other conditions. So in someone that has a mood disorder, starting certain medications can actually trigger, a worsening of that mood disorder. Right. And in those cases, we really want to be on top of it to be sure that doesn't get out of control or cause a problem. But in terms of over-reporting, I think what happens is some of our patients are very in tune with what's going on with them, which is a good thing. Right. And I think reporting everything that happens is also important because we as providers need to know what's going on. So I don't discourage the reporting of any sort of adverse effects, but just discussion with your provider and understanding that the symptoms you experience may not be directly related to the medication, but may be something else going on. So just maintaining an open mind when it comes to, discussing these symptoms, that it may not be just because you started medication X that now you have this problem. There may be something else going on.
Right. So it's
for me, the way that I usually
Go ahead.
Go ahead. I'm sorry.
I was going to say. Go ahead.
Go ahead. I'll stop.
I was going to say it's better to err on the side of over-reporting than under-reporting then.
That's my preference, only because I don't want to miss anything. There are patients that actually don't report anything, and they'll be miserable for months sometimes. Right. I tend to see patients that have breakthrough seizures pretty frequently, and actually depends on their seizure frequency. That determines how often I see them, but I would hate for my patient to go even a week, if not 2-3 months, with medication side effects that we could have easily addressed, or other things that may be going on with them that we could have addressed. There's some things that may prompt a referral to their primary care physician or maybe to a different specialist. And again, because mood disorders are very common with epilepsy, getting a psychiatrist or psychologist involved early is also very important. I think we have to treat people from all facets when it comes to epilepsy. We can't just focus on the seizure control, but there's everything else that goes along with it that helps you function as an individual that also needs to be paid attention to.
Right, right. Okay, so taking daily medications is the primary treatment for epilepsy, but the use of as-needed benzodiazepines can be another component of medication management. Can you talk about the different ways in which benzodiazepines can be used and how patients can make sure that they're using them safely and effectively, and also just kind of give a few examples of the different benzodiazepines that might be used?
Sure. The ones that are used more on an as-needed basis would be things like Ativan, sometimes Klonopin, and then diazepam, either Valium or rectal Diastat.
Mm-hmm.
With those medications, the Diastat in particular is more of a rescue medication. So in patients, particularly pediatric patients more so, or our impaired patient population, if there's a cluster of seizures or a prolonged seizure, then the caregivers may have Diastat on hand to administer. With Ativan and Klonopin, those are typically used for patients that do have clusters of seizures as well, that they either can identify a trigger for, or maybe on a routine basis they may take medications. For instance, I have a patient that gets excited, and that tends to trigger his seizures. So whenever they're going out to do anything fun, which for him qualifies as just about anything, from playing baseball to going on a field trip, he may take a medication like a Klonopin before going to help decrease his frequency of seizures.
Okay.
Another patient population that I use benzodiazepines on an as-needed basis would be patients that have what we call catamenial epilepsy, so are women that have epilepsy around their menstrual cycles.
Mm-hmm.
So I may have them take an Ativan once a day for maybe a few days before their menstrual cycle to a few days after their menstrual cycle, depending on when the seizures tend to trigger, to help control those specifically during that time. What we're trying to do is avoid putting a patient on a medication on a daily basis for something that happens of a sporadic nature. So if we only need it once a week for a month, and that tends to be the only time seizures occur, then I'll cover them for that week with a benzodiazepine, and then they'll come off of it. Right. One of the concerns with benzodiazepines, and that can be anything from Xanax to Valium, is the abuse potential, tolerance potential, dependency. Mm-hmm. It's a medication that's actually very highly abused. And when I prescribe them, typically there's a limit on the number. And I think for patients, to be sure they're using them safely and effectively, that they only use them when they're prescribed and only at the dose that's prescribed. So they don't take extra. They don't take extra if they feel funny. They don't have multiple medications coming from different providers, what we call doctor shopping sometimes, right. And then being sure that it actually works. So only taking them if it works. If I prescribe a medication and you take it and it doesn't help, then we need to not take that medication. Right. Of course, we need to have a discussion about it, but I'm likely going to prescribe something else or do something different, and that's a medication that you shouldn't have to take if it doesn't seem to work for you and you don't have that condition. One other time that I prescribe benzodiazepines is in the case of a patient that may have an exacerbation of seizures because maybe there's an illness. Patients with epilepsy tend to have more seizures, well, not all of them, but some patients with epilepsy tend to have more seizures when they have an infection or illness. Mm-hmm. When that happens, I may prescribe daily benzodiazepines to take only during the time of the illness and maybe a few days afterwards to help them during that time frame because we know they're going to have an increase in seizure frequency. Sure. I know this is not a long-term increase in seizure frequency, so starting additional medication or increasing their medication doses is not necessarily needed at that time, but they need additional coverage to help get them through that time frame. Right. So those are all different ways that I've used benzodiazepines, and again, because they are medications that can be highly abused, create a lot of dependency in the body, something even beyond our own voluntary control. It's really important that we only take them when we need them and at the doses that are prescribed.
Right. So, you've talked about when you're in a temporary situation where you know you're going to be exposed to a certain trigger, like your menstrual cycle, or like if you're going out to an event and you're excited, or you mentioned a few other examples. Are they fast acting enough to use in the case of having an aura prior to your seizure? Like if you have a reliable aura before your seizure, and that's usually 30 seconds to a minute or so. So are they fast acting enough to ever prevent a seizure in that situation?
I would say if it's a situation where the aura precedes the seizure by only 30 seconds to 1 minute, then no.
Okay.
One of my concerns with seizure propagation that happens that fast is that the patient may attempt to take the medication, and if they're going to take it by mouth with a drink of water, say, by the time they actually get it into their mouths, and they could choke on the water or the pill itself during the seizure. So for me, that's always something that I'm very leery of. What it can do in patients that have auras and or just tend to have clusters of seizures or recurrent seizures. If they have one, they may have another one. I have some patients that report, I may not have any seizures for weeks, but if I have one, I'm going to have one or two more. Right. In those cases, taking the benzodiazepine after the first seizure is not a bad idea because that'll help prevent any additional seizures.
Sure. Okay, so keeping a seizure diary or a seizure journal is a great way to begin to recognize seizure patterns. So like by patterns, we mean, for example, seizures taking place, at certain times during the menstrual cycle or at certain times of the day, like they're more likely to happen when you wake up or in the early afternoon, or and also a seizure journal can help you to recognize seizure warnings, so that can be auras, like we mentioned, or there's also premonitory symptoms, and sometimes that can just be not feeling right for a few hours or even a day before a seizure, or having a headache, or being irritable, or other kind of more vague symptoms that just indicate that you're at a higher risk of having a seizure. And then also the journaling can help you to recognize seizure triggers, things like sleep deprivation or stress. Can you talk a bit more about what types of information should be tracked in a seizure diary?
Sure. All those things you just mentioned regarding the triggers, time of day, if there's some other identifiable factor that went along with the seizure or preceded the seizure, those are all very important details for us as epileptologists to know, because it may help us identify your pattern of seizures. Then we know how to aim treatment a little bit better. If you are the kind of person that does need that temporary medication treatment, maybe for some exacerbating factor that can be predicted. Other times, it helps us understand when to expect the seizure to occur and to know when you're doing better, if there's certain triggers that you're exposed to and maybe you don't have a seizure as we're pursuing treatment. In terms of what kind of information should be tracked, so along with the triggers or any other sort of presenting symptoms, what actually happened during the seizure, if there's anything that was witnessed by a bystander, whatever the patient remembers, if there was an aura, how long the seizure lasted is important. Initially, it helps us to establish what a typical seizure is like for our patients, because then we know what to do if we see something that's atypical. Right. Usually when there's something atypical that presents, we want to investigate and find out, is this still seizure-related or is this something else? Because we may need to treat that with additional seizure medications and maybe even do additional investigations to see if anything's changed with the seizure control, with the EEG or with an MRI in certain specific cases. Right. So again, the seizure type, the seizure duration, how the patient felt afterwards is always useful information as well. And then to know how frequently they're occurring. So I like to have a date, of course, and maybe a time of day written down so that I can, again, look to see if there's any sort of a pattern to this. At least I'll know how many seizures the patient's having per week or per month based upon that seizure journal or seizure diary. So all of those things help us to make better decisions when it comes to making recommendations for medications, maybe altering different activities that the patient is involved in. Patients that want to travel, this information can be really important because we'll have an idea of what your seizure control is like, what kind of things trigger your seizures, and help you plan better for a vacation, especially if it's out of state or out of the country.
Right. Have any of your patients used any of the seizure tracking apps that are out there, or the online seizure tracking software or programs, or web-based, I should say? Is there any additional value to that, or is it even possible that they could give you too much information and you wouldn't even have time to sort through it all, or what's your thought on those types of apps?
Well, one, with the apps, I think, yes, I do have patients that use them. My patients use a variety of different ways and systems to keep track of seizures. I have some that bring in calendars with the actual seizures written down with, some details varying from an aura or a trigger to how long the seizure lasted. I think it's really person-dependent. Each individual, each patient should decide what works best for them.
Right.
Some people like to write things down. I think when it comes to apps and web-based systems, those are convenient as well, especially if it's on a smartphone. That gives a patient, especially someone who's sort of more tech-friendly, that gives them the ability to record their seizures, the information, the details, whenever the seizure happens, as opposed to waiting until they get somewhere where they can write it down. Right. But I think it all depends on that patient, their lifestyle, and what's convenient for them. I think as long as we get the information, then we're good. Right. Again, I'm one of the people that I prefer more information than less because I can always sift through what I think is important or not. Sure. And depending on what comes up, I don't know if any of the patients online have, on the phone have come across this, but I found that sometimes when I have patients, and, though I've seen them several times, as we have discussions about their seizures, there are times when certain things come up and, we want to go back and take a look, hey, every time I had a seizure, I noticed that I was doing this. It may not have been something that was apparent from the beginning, but as time evolves, we may find that there are triggers or are links to some of the things that are happening. And so I think being able to go back and have that information is always nice.
Right, right.
To not have, I wouldn't get obsessed about having a fully detailed journal. I think any information is better than no information. Right. But again, sometimes those little details, even though we find that they may not be as useful initially, in the future, they may become more important.
Right, right. I remember one person talked about having seizures at a specific time every day, and we talked a little more, and it sounded like it was basically right, the hour or two before she took her afternoon dose of her medication, and kind of thought, well, is that possible that her blood levels were starting to get low at that point, and that was why. Do you ever prescribe extended release versions of medications when you encounter problems like that, or what are other ways that you can manipulate the dosing so that people have fewer of those troughs or in terms of blood levels?
Right, or what we would call wearing off.
Mm-hmm.
So with patients, I definitely do have patients that report wearing off, and depending on when it happens, I've done anything from increasing the maintenance dose, so if it's a once-a-day or twice-a-day medication, increasing the dose of the medication to help give them a higher level for a longer period of time. Yeah. I've also had patients separate the doses out, so something that may be twice a day, we may actually adjust the timing of the doses because they may find that, well, this patient has more seizures in the afternoon hours. They're not due for their next dose of medication until early evening. If we move that one back, we may actually be able to account for seizure control a little bit better. If I increase the dose and maybe add a midday dose in there without touching the PM dose, that may also be something that's effective. Mm-hmm. So when you do see that sort of a breakthrough seizure during the time that the medication dose is due, there are lots of different things you can do to help combat that. It's really patient independent. Every patient's different with what works for them, but these are all things that I think observing, documenting, at home, and then bringing to your healthcare provider to discuss. These are all things that help control the seizures better.
Right.
I think there's really not a cookbook recipe that works well for every patient.
Sure.
There's probably no patient I've seen that's been on the exact same medication regimen with the exact same results for the exact same seizure type. Every patient's completely different, and what works for this patient may not work for that one. I have patients that do report having what we would think of as being a cyclical nature to their seizures where, at a certain time of day, like you mentioned, or I have one recently that I learned about that has seizures during certain phases of the moon. Mm-hmm. For me, that was new, but again, it kind of goes back to the circadian rhythms that are controlled by our brain.
Right.
My assumption is that this must play a role. There's a lot that we don't know about epilepsy, a lot that we're still learning. But when we have things that are cyclical like that, these are ways to help us predict what's going to happen if consistently we find that this time of day, this is what happens, that we have a seizure. That helps us direct treatment a lot more specifically to help combat that.
Right. Okay, so let's talk about some of the most common seizure triggers. We've already discussed medication, and missed medication is probably or possibly the most common seizure trigger. Another common one is sleep deprivation. So can you talk a bit more about the importance of good sleep habits in maximizing seizure control and overall health?
Sure. When it comes to seizures, one of the well-known triggers for a breakthrough seizure is sleep deprivation. So patients with epilepsy that don't get enough sleep can definitely have more seizures. Sometimes the lack of sleep can be due to stress, and I think when it comes to overall health, having good sleep habits in general helps to reduce stress. There are lots of other things that we may need to investigate that may come about if we're finding that a patient has chronic sleep deprivation. Again, sometimes there's stress, sometimes there's anxiety. Again, mood disorders are not uncommon with epilepsy. Maybe there's anxiety or depression that needs to be treated. Other times there may be other conditions like sleep apnea that may be preventing our patients from getting a good night's sleep. And in those cases, we want to be sure that we refer those patients to the appropriate specialist, typically sleep health, to have the studies done and see if they actually need to have a sleep apnea treated. All of those things can help control seizures once the sleep improves. So from a seizure standpoint, having good sleep habits can definitely help. And then in overall health, it does help reduce stress, anxiety. And again, I think when it comes to memory loss that some of our patients experience, sleep is actually when we start to consolidate our memories for the day. We transfer things from our short-term memory into our long-term memory. If you're not getting good sleep, then our patients tend to have more memory problems as well.
Right.
So sleep can be important for a variety of different reasons.
Right. So you mentioned sleep disorders like sleep apnea, which are more common in people with epilepsy than in the general population. And then also there's possibility that people are having seizures during sleep, which could disrupt sleep and reduce sleep quality. And then also medication side effects. Are there ways then that you can manage that aspect of sleep or change medications or change treatment so that seizures or side effects are not impacting sleep as much?
Oh, definitely. And again, that goes back to discussing things with your healthcare provider. When it comes to side effects, especially if they do disrupt your quality of life, so your ability to do whatever you need to do on a daily basis, including sleep, those are medications that we need to adjust and or look at doing something different with, sometimes even timing of medications. On occasion, we may have patients that actually become more alert when they take medications. Typically, our seizure medications are more sedating, but in some cases, we do get this opposite effect. And if that's the case, we may want to look at timing the medication a little bit differently, maybe giving it earlier in the day as opposed to at night, or maybe a few hours before bedtime as opposed to right before bedtime, to help ensure that our patients do get that quality sleep. When it comes, again, to seizures at night, that's actually really important to be aware of. Not everyone is aware of their seizures, but sometimes patients wake up in the morning with some sort of an indication that they may have had a seizure overnight, anything ranging from wetting the bed to maybe feeling confused in the morning, finding that they've done things at night that they don't remember, or, of course, it being witnessed by a caregiver or a spouse. And in those cases, those are seizures we also want to be sure that we're treating effectively. So that may prompt a change in medication management to help control seizures as well.
Okay. And are seizures that are less likely to be remembered or noticed by a family member, are those still likely to impact sleep quality, even if you have just one of those, or if you're having, let's say you're having them regularly but they're just going unnoticed? Is that something that can, just a single complex partial seizure or something like that could, would that really disrupt sleep significantly enough that it would actually cause sleep deprivation and then lead to more seizures?
That's an interesting question, only because if it's one seizure, probably not as likely, but if you're thinking about a patient that maybe has a complex partial seizure at night, the seizure is going to cause a disruption in the sleep-wake cycle. So on EEG, we can actually see when the seizure happens and the disruption of sleep. Just because the patient doesn't remember it, there is really no way other than with video EEG monitoring or some, witness to the event to really know what happened after the seizure occurred. So during the post-ictal period or the after-seizure state, I've had patients that have actually gotten out of bed and attempted to go to the bathroom or gone to the bathroom in the wrong place or have gone into the kitchen and attempted to cook, or lots of different things that people do in this post-ictal sort of confusional state of mind, and they have no clue that it's happening. So it's not just the seizure that's causing a disruption in sleep, but sometimes even the post-ictal state that's causing a disruption in sleep, and that the length of time of that can vary anywhere from a few minutes to even hours for some patients. So all of these things are going to take away from their ability to have a good night's sleep. In addition, after a seizure, again, I do have patients that have reported, although they don't remember having the seizure, when they wake up in the morning, either they've wet the bed, maybe they've bitten their tongue, they may be confused. It helps. It causes the patient to not feel as rested in the morning. So that may increase stress and or anxiety. And this happening on a routine basis can definitely cause sleep deprivation and lead to an increase in seizures. Right. So I would say even though the seizures are occurring at night, they can still be very disruptive.
Right. And because sleep and epilepsy are so closely tied, can a sleep study and video EEG monitoring be done at the same time, or if someone had seizures that seem to be tied to sleep, that would make sense to do both at the same time? But can that happen, or do you typically have to do them separately?
It really depends on the institution. Right. So video EEG monitoring in general, we can always do an overnight study. Mm-hmm. Granted, it's only a sampling in time. It's one day out of X number of days that this may potentially may potentially occur. But at least it gives us some insight into what's going on with the patient. And if I have a patient that consistently wakes up either wetting the bed or doing strange things at night, we've routinely admitted them to our monitoring unit for recording to see what's going on during sleep. Are they having seizures that are unwitnessed and, of course, not remembered by the patient? When it comes to the sleep study aspect, so during a sleep study, they monitor the brain activity for sleep. That's actually how they diagnose which stage of sleep you're in. Mm-hmm. They also have additional what I'll call leads or electrodes. They have some on the arms, some on the face, they have several on the chest, and these all monitor movements during sleep, breathing rates, things like that. So with our video EEG monitoring, we don't tend to have the additional leads. We have all the electrodes, but we don't have the additional leads. So to do a sleep study while you're in the monitoring unit, at some places it's possible. It really just depends on the capability of the hospital. Something that here we don't do that. We haven't been able to get it set up effectively. But on the opposite end, when you go in for a sleep study, where they do have, they have a smaller array of electrodes. So they only put, I believe there are 8 electrodes they put on the scalp as opposed to the higher number that we use in EEG monitoring. And then again, they have the chest leads and some arm and leg leads and things like that they use. We can always request that they add additional electrodes to that. I actually have a colleague here in the office that we routinely do that for if we're concerned that the events at night may not just be sleep-related but may actually be seizure-related. Right. So we'll add additional electrodes so that we can monitor the brain in its entirety while they're also having the sleep study done. It's just done through sleep health as opposed to in our monitoring unit.
Okay.
And then the interpretations can be made the exact same way.
Sure. All right. So stress is another commonly reported seizure trigger, and because we just had a recent call earlier this year on stress management, we won't go into too much detail here, but can you talk briefly about how to manage this common trigger?
Sure. I think in general with stress management, knowing the triggers for stress is really important. Sometimes that's easier said than done, but I think with the help of family members and then also our behavioral health specialists, or like our psychiatrists and psychiatrists, I really refer to them quite a bit when it comes to stress management because there are different techniques that they use that I find can be helpful for people across the board, specifically people with epilepsy, because stress can be a common trigger, but they can teach coping mechanisms, help work through maybe some common life stresses that may exist. And if there's anything that's a bit more complicated, then they're very skilled at being able to work through those and help direct treatment and management there. So what I look for is definitely relaxation techniques. Again, going back to sleep, making sure that our patients get a good night's sleep because that can definitely contribute to stress. And then if there's anything additional that may need to be managed a bit more by our behavioral health specialists, getting them involved as early as possible because overall our goal is for our patients to have a good quality of life. And all of these different factors can definitely impact their quality of life.
Right, right. And certainly, just like you can keep a seizure journal, you could also keep a journal related to your stress where you keep track of the different things that, when you're feeling stressed, what was happening before that made you feel stressed, or when, what did you do to cope with that stress? Was it effective? All of that kind of thing can certainly help to manage stress as well. So
definitely, and also eliciting family support or social support. So if there are certain things, we all have life stressors with kids and work and, just sort of day-to-day activities. There are stressful events that do come up that I think having additional support, a good support network, family and friends, can really help you get through as well. So maybe, if your workload is too heavy, maybe trying to find ways to divide out some of the responsibilities or to prioritize responsibilities. So a lot of those different things can be helpful. Again, whether these are people with epilepsy or not, stress is always something that's really a problem for a lot of us, and there are lots of different ways to help combat it.
Right. Okay, so photosensitivity is a trigger that, at least in the literature, affects about 3 to 5% of people with epilepsy. But just based on my experience in talking with clients, and it seems like a much higher percentage of people with epilepsy report photosensitivity as a trigger. And often it's with things like TV, computer monitors, and cell phones, or even bright lights that aren't even flashing, and then other types of stimuli that really shouldn't trigger a true photosensitive seizure. When people talk about TVs being a trigger, often if you look in the literature, it was back when they were the old, really old TVs that had a much more visible flicker, and the newer TVs don't really flicker in that frequency range. So what are some possible explanations for this discrepancy between what's reported in the literature and what's reported anecdotally by patients?
Well, I think that's a complicated question to answer, only because I think there are lots of different ways that can be interpreted.
Yeah.
Photosensitivity, as you mentioned, sometimes it's not simply that the flashing lights are producing this response. Mm-hmm. I guess my first question would be whether or not the response that was elicited was truly a seizure. There are lots of patients that have had spells of some sort where there's an alteration in their level of consciousness from baseline and they return back to normal. And in the past, we've always said, that it sounds like seizure, we'll treat it with seizure medications. Mm-hmm. So there are patients that have been diagnosed as having seizures and or epilepsy that may actually have what we call non-epileptic events that are triggered more by stress. Oftentimes in that patient population, a lot of the, stimuli that shouldn't really trigger a true photosensitive seizure, those tend to occur. In patients that have diagnosed epilepsy, sometimes there are other things that can be going on during the time that they are exposed to that trigger, and it's referred to as photosensitivity. They may be stressed at the time, or there may be something else going on. Maybe they missed medication. Maybe there was some other trigger, illness, and it was coincidental that they were exposed to something, again, that shouldn't necessarily trigger a true photosensitive seizure. I think the way to make the diagnosis about photosensitivity is really to get the EEG and expose the patient to that trigger, right, and see what we find on EEG. That way we can document if it's actually photosensitivity and seizure, or if it's something else. If it's something else, we want to know we want to be able to identify that it is something else, right, so that we're not chasing that with seizure medications. I would hate to just increase seizure medications, change seizure medications on the basis of something that actually was not seizure. Right. Again, I think there are lots of different things that patients are exposed to that aren't typically thought to be triggers for seizures that we do find out are seizures, and I don't have a good explanation for that. I'm not sure why it is that, certain things can actually trigger an epileptic seizure. Is it just coincidence at that time the going to have a seizure and you just happen to expose them to a light or not, or if there is something else happening on a biologic level that we just don't have an explanation for right now.
Right.
But I think in general, that's sort of my approach when it comes to photosensitivity, especially when it's something that shouldn't really trigger a photosensitive response, just being sure that we know what it is and what it's not before we chase after it with medication.
Okay. And for those who are photosensitive, what are the best ways to minimize photosensitive seizures?
What I usually do is advise, of course, avoiding exposure. If we know there's something that triggers sensitivity or that triggers the seizures, we want to avoid that stimulus if possible. I do have patients that use just traditional sunglasses, and it tends to be effective for them. I hate to say it, but every patient is completely different. Some people can shield their eyes and be fine, while others can't. There are polarized sunglasses out on the market. I can't say how effective they are or not, but from what I understand, they've been specifically designed to help with photosensitivity. I believe those are the blue sunglasses that have been referred to in the past. There's also covering one eye if they're exposed to photosensitivity. I'm not sure if that's effective or not. I actually have not had any patients of my own try that or report any results from that, so I can't really comment on that one. But in general, trying to find ways to either avoid the stimulus or reduce the intensity of the stimulus if possible.
Okay. And then for those who have no, let's say you do a test and you expose them to what they think is a trigger, but it actually isn't a trigger, do you feel it's best to advise the patient to simply avoid those triggers even if they're not true triggers, or is it better for them to learn that they aren't photosensitive and then try to work on what else may be causing the triggers, like maybe anxiety related to their perceived photosensitivity?
Right, and that kind of goes back to what I mentioned before. I'm more of a type that I want to be sure we know what it is. So I want them to learn if it's not photosensitivity, and then I can use that information to help reassure them that they're not photosensitive, at least to the triggers that they identify. Anxiety is something that does happen a lot with patients with epilepsy, and I can understand it. Not knowing when a seizure is going to happen, where you might be, how it may affect you, who you may be around, all of those different things about seizures in general can trigger anxiety. And then there's the underlying neurochemical changes that happen that can also make anxiety a bit more common. So it's not unusual to have anxiety when it comes to epilepsy, but I think helping patients, I believe in my patients being informed, giving them information and helping them understand what is and what's not true about what they're experiencing, and then helping to work through the details, the anxiety that may come along with that, is, to me, the best way for me to help them.
Sure.
That way they're not avoiding things they don't need to avoid or not participating in activities that they may actually enjoy because they have this perceived idea that this may not be good for me.
Right.
By giving them objective information, actual real data to say, hey, we tested it, we tried it in a controlled environment where you have healthcare professionals here. If something were to go wrong and you're fine, that helps them to also be more confident that when they're exposed to it, that they'll be okay. Right. But it's a process. Yep. It's not going to happen overnight, but I think that's something definitely, as a medical professional, I can help do my role in trying to reduce their anxiety overall.
Okay. So alcohol and caffeine are two substances that can sometimes be tolerated in moderation by some people with epilepsy, but they can also be triggers for others, particularly when consumed in excess. Can you talk about how you counsel patients regarding these substances?
Sure. When it comes to alcohol and caffeine, I definitely am one to promote abstinence.
Right.
When it comes to alcohol in particular, it's difficult for us to know if seizures that are happening, especially breakthrough seizures, are seizures that are related to alcohol use or if they're seizures related to the epilepsy. If it's seizures related to epilepsy, then I can make medication changes and or recommend additional treatments to help get seizures under control. But if it's alcohol, the only thing that really stops alcohol-triggered seizures is to stop drinking. I do have patients that I've seen in the hospital here that it's hard to make the determination if they're drinking and having seizures. I'm not sure if the alcohol is causing the seizure, if they really do have a seizure disorder that needs to be addressed. It's hard for us to know what to do in those circumstances. So avoiding those triggers or avoiding those substances can be the best way to help us understand what the true diagnosis is. We don't want to assign someone a diagnosis of epilepsy if they really had seizures because of alcohol or excessive caffeine use. If it's a diagnosis we give, we want to be certain that we're doing the right thing for our patients by giving medications and attempting to treat them. Medications don't come without side effects. They're not necessarily substances that, don't have any effect on the body. We want to be sure that if we're giving these medications and taking those risks, that we understand that we're doing it for the benefit of the patient, not because, they're drinking alcohol. And actually, despite how many medications I give, without making the patient comatose, if they're drinking alcohol, the likelihood that we have breakthrough seizures is pretty high. And there's not a lot I can do until the alcohol is taken out of the equation.
Right. Okay. What are some commonly used medications that can lower the seizure threshold and potentially trigger a seizure?
Unfortunately, there's a long list. In theory,
maybe some of the ones that are like over the counter that people wouldn't necessarily think of as being a seizure trigger.
In terms of over-the-counter medications, there aren't very many that I'm aware of, other than recreational drug use. Those can definitely trigger seizures, and then alcohol. A lot of the medications, especially the ones we use for depression, anxiety, and psychosis, things like bipolar disorder or schizophrenia, a lot of those medications do come with the warning that they may cause seizures. Mm-hmm. We use a lot of those medications pretty safely. Again, because a lot of our patients with epilepsy have mood disorders of some sort. There are a lot of patients that are actually on these medications despite that warning, but they do well. They do fine. Right. It's actually very infrequent that we see seizures associated with those medications. There are some medications that we tend to see a higher proportion of seizures with. One of those can be Wellbutrin. There are a couple other ones that are antibiotics that we use that we try to avoid in patients that we know have seizures. So when patients come in and they're on the medical floor, they're getting treated with antibiotics, typically we do a good job with avoiding certain medications like Acinazid and metronidazole, a couple things that we use for treatment of urinary tract infections and other infections. We try to be sure we use an alternative as opposed to those that we know can trigger seizures in our patients with epilepsy.
Mm-hmm. What about Benadryl? I've heard that that's one that can sometimes be a trigger.
I haven't commonly seen it be a problem. Okay. I'm still relatively early in my career, I guess, compared to a lot of my colleagues, but I have not seen that as an issue. And I would say in regular doses, so anything from maybe 25 milligrams once a day, and occasional use. I actually have a patient with pretty severe allergies that she's been on pretty high doses, and it seems to not have affected her. But I think with every patient, if there's a concern that any medication, whether it's known to cause seizures or not, there's a concern, I would definitely encourage them to talk to their healthcare provider because there are things that come up that we may not be as aware of that we may need to look into a little bit further. If we find that consistently, if you take medication X, whatever that medication may be, and it triggers seizures, that may be something that we need to investigate, although it may not be something that has been well-defined in the literature or through our research. Sure. So I never exclude the possibility that it may be contributing, but again, when it comes to things like Benadryl, I haven't really seen that personally, but I can't say that it doesn't happen.
Okay. Can you talk about some of the other commonly reported seizure triggers and how to manage them? Just things like low blood sugar or dehydration, overheating, fatigue, illness, things like that. I think you mentioned illness already in the use of possibly using benzodiazepine during an illness, but just any other thoughts on any of those other triggers that we haven't discussed yet?
Yeah, definitely. For patients with low blood sugar, being aware of, the number of times they eat per day, the fact that they need to eat, just staying on top of their eating habits is always a good thing. I think with those patients, typically there's a feeling that precedes the seizure. Sometimes there's shakiness. Sometimes there's just acknowledgement that it's been several hours since I last ate. People need to eat a bit more consistently if they have seizures that are related to lower blood sugar. An evaluation by their primary care physician is probably also important to be sure that they're not having any problems with insulin, right. To be sure there's no underlying issue triggering the low blood sugar. When it comes to dehydration, overheating, fatigue, always taking a break, time out, being well hydrated, those are all things that are very important, especially when it comes to some of our impaired patients that may not be as aware of these different symptoms that may come along with dehydration and or overheating. Being sure that a caregiver is involved and can have them take a time out for a few minutes. If it's a hot day, making sure they get a drink of water periodically. So really just keeping up with a schedule of things to be sure that, they're not going too long, again, without meals or without water or, in warm weather without someone addressing that. When it comes to fatigue, we sort of talked about that too, with sleep deprivation in particular, but in general, our patients that have seizures that are triggered by fatigue, I think learning what the warning signs that your body may exhibit for a patient that, that can be aware of that and taking a break. I think from a healthcare professional standpoint, we tend to be very supportive when it comes to helping our patients get accommodations in the workplace as needed when things like this come up. If there's a certain trigger or stimulus that may be there that may trigger their seizures or typically any other neurologic disorder, but seizures in particular for us, and helping to make accommodations at work to prevent those triggers from causing problems. We want our patients to be as functional as possible, to be able to do all the things they want to do during the day, and whatever support we can give them, we typically are able to do. We'll do whatever it takes to help.
Okay, great. So another aspect of epilepsy self-management is risk management. And again, we won't go into too much detail because we did do a call on that a couple of years ago. But can you talk about the key risks that people with epilepsy should discuss with their neurologist, and then the most important things that they can do to reduce those risks?
Sure. I think some important risks are definitely to be aware of safety risks, to discuss, your job or activities that you may be involved in, any travel that you may be interested in pursuing. These are all important because we want to be sure that if there were something that would happen, that we're prepared. There are certain occupations and then also certain activities that can be very risky to be engaged in if you have seizures. I usually describe it as just sort of any activity where if you were to lose consciousness, you could hurt yourself or someone else. We either need to avoid it completely, or it has to be done with supervision. Because when a patient has a seizure, they may or may not have a warning. They may or may not have an aura. And the seizure can also progress pretty quickly to where they have no voluntary control over what's happening. If they're engaged in an activity that can be harmful to themselves, such as cooking or swimming in a pool or certain sports activities, they can actually injure themselves pretty severely, if not fatally, if that seizure were to happen. When it comes to things like status epilepticus, which is, again, just a tendency towards recurrent seizures, so patients that have seizures without return to baseline in between, or seizures that happen on a recurrent basis. So these are situations where we actually have our patients go into the ER for evaluation, management, and sometimes it requires us to give anticonvulsant medications here at the hospital at higher doses. But those are things that definitely should be discussed if there's a person that has a tendency to go into status when they have seizures. When it comes to depression, SUDEP, just basically understanding what those situations are, what the signs and symptoms may be, and then what you can do to help. I would say the majority of the risks that are out there are all things that should be discussed with your provider to be sure that we're doing everything we can to help optimize their care, to help optimize their quality of life.
Okay. So a lot of studies have shown that people with epilepsy as a group tend to have worse overall health than the general population, and that can be due to a number of factors, such as medication side effects or the effects of the epilepsy itself or the underlying conditions that cause the epilepsy. It's also possible that having epilepsy just makes it harder to practice healthy behaviors. So, for example, epilepsy can interfere with sleep. Medications may affect appetite or metabolism, which could lead to weight gain, and fatigue or fear of seizures may make people with epilepsy reluctant to exercise. Some people may also be so busy with managing their epilepsy that they don't have time or energy to devote to their overall health. So we've already talked about sleep and stress as two health-related behaviors that impact not only seizures but overall health. Let's talk briefly about diet and exercise. Those are obviously play a huge role in your overall health. The extent to which they are related to seizure control is less well documented. But let's start with diet. So with any chronic condition, there are all kinds of opinions and beliefs about about foods that you should seek out or foods that you should avoid, and that's certainly true with epilepsy as well. But other than the ketogenic diet and its variants, are there actually any foods or ingredients that have been shown to either protect against seizures or contribute to seizures?
From what I understand, I would say no.
Okay.
There's a chance that with soy, at times it's been linked to having higher estrogen levels in the body.
Okay.
Estrogen is a hormone that women produce naturally, but when it peaks, especially during the menstrual cycle, its progesterone level drops. So when there's a higher proportion of estrogen in the system, that actually can trigger seizures. So I guess there's a chance that soy products could cause seizures, but I don't think that's been very well documented.
But yeah, that kind of makes sense, and that someone who maybe if someone was on a very high soy diet, like if they're a vegetarian,
exactly,
on very high levels of soy, and it might be something you would at least have to pay attention to.
But in general, I would say no. There aren't any foods or ingredients that I'm aware of that protect against seizures or actually cause seizures.
Okay.
I'm not sure if you're aware of any, Russ.
No, but again, it's the same thing. I hear a lot of people say, "Oh, if I have artificial sweeteners, or if I have red dye number 43, or whatever, or if I have too much of this or not enough of this, I have a seizure." So, I mean, I think in those cases, as long as if they're avoiding certain foods because they think they cause trigger a seizure, as long as it's not like healthy foods like vegetables, and then I don't see any problem with avoiding certain ingredients if you think that it may cause a seizure. So even if it's not documented in the literature, it's still, I think, trusting your body and trusting your instincts on that makes sense, as long as you're not depriving yourself of something healthy.
Right, and actually in those cases, what I also do is I'll evaluate patients in the monitoring unit. If we're having a situation and there's certain things that the patient finds as being a trigger, while we're here, I always tell patients I'll do anything and everything I can to bring it on, to bring on the seizure, so that we get a diagnosis, so we know what things we do need to worry about and what things we can just sort of maybe have counseling about, or help understand maybe it's not what we thought it was, that maybe it's not a seizure. When it comes to some of those substances you mentioned, like the red dye, I know with ADHD, I think that comes up as an issue, but again, I don't see pediatric patients with ADHD, so I'm not as sure, but I've also heard those different opinions and beliefs about some foods. But what I would recommend is if there's a patient that is convinced that there's something in particular that triggers their seizures, it's not hard for us to evaluate that. All we have to do is just do the EEG monitoring and expose our patient to whatever that substance is and see what happens. I've had people here in the monitoring unit where they have had artificial sweeteners or junk food. That's one of the other ones that's come up. If I eat too much junk food, then I'll have a seizure. I think in certain cases, again, it may be coincidental. Maybe that particular day you just didn't eat very well and then you had a seizure. It may not be just the change in diet that may be causing the problem. But I think definitely investigating the situation is worthwhile. So that's typically what I would do for my patients.
Sure. And as far as having a healthy diet, I think it just makes sense to have a healthy diet because it is going to improve your overall health. And it may contribute to better seizure control. And so that's, even though there may not be a lot of direct evidence of the impact on nutrition or diet on seizure control, it certainly can't hurt. So there is some evidence that exercise can improve seizure control in addition to the numerous short-term and long-term health benefits, which includes improved cognitive function and mood, and that's a particular value to people with epilepsy. But in rare cases, there have been cases where vigorous exercise can be actually a seizure trigger. So how can people with epilepsy determine what type and level of exercise is both safe and helpful for them?
I think that's something that needs to be discussed both with their neurologist as well as their primary care physician, depending on their health or fitness level, which, again, we'll sort of need both the input from both physicians to decide. That'll help determine how much exercise is going to be safe for you and also helpful. There are other conditions that we want to be aware of to be sure there aren't any cardiac issues, any breathing issues, and those are all things that the primary care physician will have more insight into than the neurologist. And then I think being sure that we understand our functional limits. So depending on if there's weakness the patient may have or any other limitations the patient may have, there may be certain exercises we may want to avoid just based upon that individual's abilities. So those are all assessments that I think would be helpful, again, having the input of the neurologist as well as primary care physician, and sometimes even a physical therapist can be helpful to help us find the best exercise regimen for a patient.
Okay. And just in your clinical experience, do you think it's more, do you more commonly see people where exercise is a trigger, or do you more often see people where exercise is perceived as being helpful in terms of seizure control?
I would probably say more helpful, only because it does help to decrease stress, improve mood, improve cognitive function. It improves their endurance level so they're not as fatigued, and it helps people sleep better at night. So there's so many different benefits that exercise can lead to that I think there's actually more benefit to it than it actually being a trigger. Right. I think in patients that maybe overheat easily, or patients that, these are more typically our impaired patients that may have some limitations in understanding what the boundaries are, that, they don't recognize the symptoms when they push themselves too hard. That can be more difficult. But as long as we have patients that are aware of what they're doing and being sure that they don't get themselves into trouble where they are overexerting themselves, overall I think exercise can definitely be beneficial. Okay,
great. So before we open it up to discussion, do you have any closing thoughts on what it takes to effectively manage one's epilepsy?
I think for me the biggest thing is being sure that our patients communicate with their healthcare providers and that they're honest.
Right.
One thing we didn't mention was marijuana, and I can understand why we didn't exactly discuss that, but I'm sure in other discussions you guys have talked about that in more detail.
Yeah.
But anything that a patient is doing or not doing has to be discussed with the healthcare provider. We don't want to make judgments. We don't want to say, oh, you should be doing this or shouldn't be doing that. We need to know so that we can help make the best choices for you. So when it comes to alcohol use, missed medications, other things that may trigger epilepsy, and again, other substances, including marijuana and or over-the-counter regimens, all of those things are really important to discuss, because without that information, we can make a decision that may not actually be in your best interest very easily. Mm-hmm. So I think having a clear line of communication with your provider, being honest about what's going on, without fear of being judged and or chastised, but just in the interest of their own health care, having an open and honest communication channel with the provider is very important.
Okay, great. So I'm going to unmute all the lines now, and again, if you do have background noise, even though I've unmuted all the lines, I still would like you to mute your individual line if you suspect that there will be background noise that other people can hear. So, and to do that, again, you can dial *6 or use the mute feature on your phone if you have one. Okay, so just a second here.
All guests have been unmuted. You will now rejoin the meeting.
Okay, so before we get to questions, wanted to ask people maybe to share some of their experiences. So we've talked about a variety of behaviors that can contribute to seizure control and wellness, but adopting and maintaining these behaviors is sometimes easier said than done. So would anyone on the call like to share an example of a successful behavior change that you've made to improve your seizure control or your overall health, and then how you went about making that change.
Hi, this is Jenny.
Yep.
And one thing I found out from a friend of mine, that caffeine can bring on a seizure.
Mm-hmm.
And I didn't know that. It had been quite a while since I had been diagnosed, and I had no idea that caffeine could bring on a seizure. Since then, I don't drink anything with caffeine. If I drink pop, it's caffeine-free. If I drink tea, it's caffeine-free. I find that has really helped.
Okay, and was that...
I love tea, and I'm so glad that you can get it caffeine-free.
Right. So that wasn't all that hard for you because you were able to find a substitute for what you were used to drinking.
Right, but if I had not been able to find a substitute, it would have not been easy. I'm just glad that there is caffeine-free, especially tea. I like pop, but I especially like tea.
Sure. Are there any, like, coffee drink? Because I know coffee can be difficult to, a difficult habit to change if you are a coffee drinker. Has anyone had any experiences with, stopping or trying to stop drinking coffee, or is anyone able to drink coffee and it's not a problem for them, or?
With me, it was Kathy. I was just, that's three things in a row that I've always, ever since I was little, always drank was caffeine pop, coffee, or tea.
Mm-hmm.
And the thing is, on my end, I feel that it isn't a problem. Maybe it is, but I don't feel it as being a problem. Mine has always been stress or if I worry too much.
Mm-hmm.
And I've learned that my seizures, just like the other day, I wasn't going to a meeting with a friend, and I started feeling nervous, and it felt like an aura was starting to come, and she made my mind get off the worryingness, made me laugh, and it just stopped.
Well, I know.
Wait,
I
don't think she was done yet.
Okay, go ahead.
And it's just that, like I said, my stress, it seems like it's always, or worrying, it always makes my seizures occur. But when she started, I told her that I felt like I was going to have one, so she just started talking about something else and made me laugh and got my mind off of it. Then I didn't have a seizure.
That's good.
That's a great approach. A lot of times in stressful situations, or you're getting stressed, your instinct might be to focus on the stress or say, okay, I've got to relax, I need to relax, and you get yourself even more worked up because you're telling yourself you have to relax. But sometimes distraction or just getting your mind off of it can be really helpful. And certainly social activity and being around others is as long as you like those other people, can be stress reducing as well. So Clinton, you had something to share?
Well, I know when I just sit down, I might have turned some gospel, some relaxing music on outside, and I'd sit there and listen to it and everything, and it will take care of things right here. Because I know this man, as you remember, Greg, I remember he told me he did the same thing. It works for him himself.
Right. So yeah, relaxing music, art, reading a good book. All of those things can be things that can help you reduce your stress if you're feeling stressed, and you kind of just need to find the thing that works for you. And it may be one thing or it may be multiple things. So, okay. So other than taking medications, what behaviors would you say have had the biggest positive impact on your seizure control or your overall well-being? So Jenny, you mentioned maybe that reducing caffeine has had a big impact. Does anyone else want to share something, a behavior or a change in your behavior that's had what you felt was a big impact on your seizure control? Anyone else have anything to share in that regard?
This is Jordan.
Yeah.
My child is only 11. He's not, a big caffeine, he doesn't sit down and drink coffee, things like that, that's for sure. And right now his seizures are not under control. We're so new at this. We've just broke into the world of epilepsy.
Sure.
I'm just pretty much learning and taking tips, and, I'm writing down as much as I can. I haven't, the only thing that has really struck me as far as what you and the doctor had already discussed before you opened our lines up was the auras. As far as, behaviors and stuff like that, my child is very active, easygoing, very funny, just full of life. So he doesn't really have any, moods or anything like that I've been able to link to his seizure activity. He got up this morning, and he was just hospitalized for cluster seizures 2 weeks ago tomorrow. And I almost lost him.
Oh, my God.
And it was the scariest moment. But he, since being diagnosed with epilepsy and being on treatments, he has not missed a dose. I'm very religious about it.
Right.
I set my alarm on my cell phone. It follows me. I follow my child around all the time just because these are so unpredictable and we're so new. We don't know his triggers yet, except for most of them seem to be visual. He had one leaving the emergency room from having two of them. He left the emergency room, was supposed to follow up with with his neurologist, and he had one in the vehicle. And we think it was just the motion of everything outside of the vehicle passing by and the lights reflecting through it. And he's supposed to wear sunglasses, but again, he was in an ambulance and they rushed him to the hospital. We didn't grab his sunglasses. So he had one 15 minutes away from the hospital, and I live approximately 40 minutes from the children's hospital. And so we're pretty much, trying to figure all of this out so we can try to help him live safe and productive, and if you will, keep him with me because it's not time, He woke up this morning, and he stood next to me, and I was, checking on him. I just kind of scratched his back, and he gave me a funny look, and I'm like, what's the matter? And he says, I don't know. And I said, does that feel good? And he said, no. And normally he likes his back scratched. So I said, well, what does that feel like? And he said, it just feels funny. I said, okay. And then another thing that he likes is to have his head scratched. So I just kind of lightly started scratching his head, and I got, around the neck and behind the ears, and he said, that feels good. I'm like, okay. Well, then I got to the crown, and he kind of flinched, and I said, what's the matter? And he said, that spot hurts. And, now I rechecked after listening to your conversation about the auras. I kind of had him come over to me, and I was, scratching the same spot, and he had no complaints at all.
Wow.
So
well,
I'm
excuse
kind
me,
of...
ma'am. I would like to tell you something, because I've been having seizures since I was 2 years old, see. And then, I know brain surgery, that might be good for your child. And also, if that doesn't work, VNS Vegas stimulator, that will help right there. Because I remember when I was younger, like your child, my seizures were under control, but they still are. I have 3 seizures a day. Yes, and I got older, I had brain surgery, and that's calmed them down a little bit. Now, I have the vagus nerve stimulator in me and everything. I can feel them coming on. I swipe the magnet across my chest, and it will stop because I woke up plenty of times myself, like you were saying, a child, and they had a seizure and everything. Yes, it will be good. Matter of fact, waking up to tell a child to sit on the side of the bed and everything. Because I woke up plenty of times, even now, it's just woke up, got straight up and fell straight out. I mean, because like I do a children's hospital. They even got my graduation picture up there on 5 Southwest, and I think yes, I've known plenty of people at that hospital.
Okay. Yeah. So I mean, we will have a call later this year on vagus nerve stimulation, so we can talk about that at that point. But Jordan, can you kind of finish your thought on the scratching and what you suspected that might be going on there?
I was listening to your conversation, listening to what you guys were saying about auras, and his neurologist had asked if if he could remember experiencing anything prior to, and what happens with his is, and again, this might be because he's so young, he just turned 11,
right,
that he doesn't really know what to look for.
Right.
And again, I didn't really know what to ask him, like in the morning, like how do you, because I'm always asking him, how do you feel? Sometimes I can look at him and his eyes, you can see a lot in his eyes, like he doesn't feel well. Sometimes, most of the time when his seizures have occurred, he has maintained normal activity. He's been nothing out of the ordinary, but sometimes he gets up and he just doesn't look like he feels well. So he, is sleeping in my room with me. The thing with his seizures are they're silent. You don't hear them. The first one he had, he kind of yelled, and then it hit him. But now there's nothing. You just, you look away from him for a second, and when you look back at him, all of a sudden he's hitting the floor and seizing. So we're trying to piece together everything that we can to try to figure out how to relate, what he's feeling to being the body's warning system for him, that there may be trouble coming.
Right.
So, this is all new to me, and I'm writing down everything that I'm hearing, everything that, I could possibly help the neurologist figure out with him, because, 2 weeks ago was my world completely stopped. Right. And he's definitely experiencing, like, memory issues, things that, that he would typically remember. He has no recollection of. He definitely has lost, now at this point, he's at a 2-day complete memory loss surrounding his cluster seizures. So I'm trying to find his aura. I'm trying to figure out what he feels before these happen. So when he felt that way this morning, and then hearing you speak of the auras, and then what I've read online about what they could feel like, or what, some patients have described, so that way I know kind of what to look for with him, because I am, I'm pretty much seizure ignorant.
So, Dr. Malone, do you have any words of advice in terms of identifying not only auras, which are really kind of speaking specifically about a simple partial seizure that precedes another seizure, and that's usually just a few seconds to a couple of minutes of a symptom, but also those premonitory symptoms that can be hours or days before a seizure, and how to kind of identify those types of things, particularly in a child where children may have a harder time verbalizing or communicating the complex feelings that they're experiencing.
Right, I agree. With kids, it can be very difficult because they don't know how to report what they're feeling, or sometimes they don't even know that what they're feeling is not normal. I think she's doing the best thing that she can do, which is definitely to make those observations. If there's any change in mood, if there's any change in behavior, if he seems to be more sedated, or if he seems to have any other changes that you may notice that may help predict when he's going to have a seizure, because right now, until he gets older and he's able to actually communicate those different feelings to us, it's really through observation that you're going to be able to pick up on any patterns that he might have. So things that may trigger his seizures, things that may be patterns to his seizures, that's really the only way to understand what's going on with him in this time frame where he can't tell us himself. So I would agree with all of the things that she's doing, definitely, and then relaying those things to the neurologist. With every patient, it is a bit of detective work to figure out what is causing it, what's the problem, what medication works, what is the pattern, what are the triggers. And unfortunately, as more time passes, it does take time. But the good thing is that in that time frame, we do start to see those patterns emerge, and we're able to handle things more effectively. In the beginning, again, it's not as much, comfort, because you really don't know which direction things are going in, what things are important and what things aren't. But at this point, I think making sure that you're paying attention to what he's doing is the best thing that you can do.
Excuse me again. Well, I was just thinking, Ativan is good because that does calm your seizures down. The Ativan, I think Ativan's good because I remember I was saying I took, phenobarbital. I took phenobarbital. That stopped my seizures right there for a little while.
Right.
They started back.
So it's different for every person, and that might be. We talked earlier about that being a potential strategy for some people. I just, because we're near the end, I wanted to make sure that anyone else who hasn't had an opportunity yet to ask a question or make a comment. Does anyone else have a question or comment?
Hello, can you hear me?
Yeah.
Hi, my name is Yvette. My son has cluster seizures, and I am open to discussing more with Jordan if she, needs more time at another day to connect with her. I completely agree with Dr. Malone on paying attention to everything, keeping a real detailed diary in the beginning. That has helped immensely. I mean, I stay in close contact with my son all day long, especially take advantage of the summertime and stick to routine. One thing I wanted to mention besides that is Dr. Malone had recommended adding melatonin to Zach's nighttime medicine, and it has helped quite a bit with sleep.
Right.
And with him getting good sleep, it allows, him not to have as many seizures the next day.
Right. Hi, Yvette. I thought that was you.
Hi.
Yeah, definitely. And those are some of the things that I encourage you guys to talk to your providers about, your doctors, to be sure that any of those things that are happening, for instance, as Yvette was mentioning, sleep deprivation with her son was definitely a big factor in seizure control. And being sure we address that, either looking into it to be sure there's no other medical problem causing the sleep deprivation or any other symptom that may be triggering the seizures, and then having that treated, that can definitely help with seizure control, sometimes more than what we can do with medication. We can give medication, but if these underlying factors aren't controlled, then seizures are going to still happen. And so by doing both, it's what I call a multifaceted approach, but basically there's several different things that we do all at once from different facets to be sure that we direct this towards seizure control, so that we're controlling sleep, making sure that he gets a good night's sleep. We're treating with medication to be sure that medications are at effective doses and that they're working. And then anything else that may be causing a stressor or triggering seizures, that we're addressing that one too. And sometimes these are all separate approaches that we have to look at, but they all, at the end of the day, impact seizure control.
Right. And
Yes.
Jordan, if you want, Yvette, mentioned that she'd be willing to talk with you. If you'd like, I can exchange or help you guys. I can email one of you the other person's contact information if you'd like.
Yes. Yeah.
Okay.
Definitely.
Great. I'd love to talk to you.
All right. I will facilitate that after the call. I'll just email both of you, and then you can exchange information. So maybe time for one more question.
I'm not sure if I should ask a question because other people I don't know if everybody else has had a chance.
Well, I'd like to ask about aging.
Okay.
But,
go ahead.
Should I do it now?
Sure.
I'm 71. I've had epilepsy for 15 years. And I wonder if it may be came with menopause. And as I age, my side effects of fatigue and not clear thinking are increasing. But I don't know if this is caused by aging along with epilepsy, like I'm too tired to travel, to exercise, and I sleep 10 hours or more a night. And I figure this is just the price of controlling my seizures, is feeling exhausted all the time.
So your seizures are under control right now?
Well, yeah, pretty much.
Okay.
I blank out and I blank out for a few minutes and have anxiety seizures. That's about it.
Okay, there could be a couple of different things going on. One, being sure that all of your seizures are under control, that you're not having any seizures that may lead to your feeling fatigued like that. Sometimes seizures that happen and we're not aware of them, one of the signs I look for is periods of confusion, periods of extreme fatigue, because these things may all come after a seizure that a patient may not be aware of. So there may be symptoms that you feel, but you're not aware that you had a seizure that was related to it. And the way we check that out is
constantly tired.
Okay. Then another thing that may be a factor is seizure medication, definitely. And that can happen from two different perspectives. One, the seizure medications themselves, depending on which medications you're on and at what doses, those can definitely cause side effects. So taking a look at your medications, seeing what you're on at what doses, we may need to make some changes to medications that may not be as sedating. The third factor in that is with age, you definitely do have a difference in terms of the impact of side effects on you. So patients that are older tend to be very sensitive to medication. So while someone that's younger may be able to take a higher dose with no problems, get the same dose as someone that's older, sometimes there's changes in kidney function, sometimes there's changes in just metabolism overall, liver function. We may have to adjust the dose downward a little bit to still account for seizure control, but then also to be sure that you're not experiencing side effects. For me, to know that you can't function, you can't travel, you can't do the things you want to do is an issue. My goal for my patients is no seizures, no side effects. I want them to be able to live their life to the fullest.
My neurologist, he decreased my Clonopin, and I was in the hospital with a grand mal.
Okay.
So I hate to change anything, you know.
Well, sometimes it's not a matter of just decreasing a medication, but sometimes making medication changes where either you take one medication and decrease the dose of one that may be sedating, and Klonopin is very sedating. So that may be one of the issues that you have. But maybe not just making a decrease in one medication, but you also have to make a compensatory or a change in the other medication to account for what we're losing. So if I'm going to decrease your Klonopin and I know it works, I need to increase something else to be sure that I'm still covering you for seizure control. At the same time, not giving you additional side effects. So there's some medication management, some changes that may be able to be made with your doses and even the medications themselves that may actually help you feel a lot better, be able to function a lot better. But again, I don't know that without, of course, seeing your medications, things like that. But you're doing the right thing by talking to your neurologist. I'm not sure if, I don't know but I would say you may benefit from a referral to an actual epilepsy specialist. If you find that if your neurologist has gotten to the point where they're not sure what else to do, then maybe they need to refer you to a seizure specialist to see if there's anything else that they can recommend. It sounds like they're talking to you.
Seizure specialist.
Oh, you already.
You said you do?
Epileptologist.
Yeah.
Okay.
Well, I'm feeling kind of fatalistic, you know.
Well, I can understand how you feel because, it is a drag to feel like that on a daily basis. But keep talking with your provider. Keep talking with your doctor and let them know how you feel.
If you ever get to the point where you feel like your epileptologist is not really willing to try new things or is being dismissive.
Well, I'm afraid to try new things. I don't want any more grand malls.
Sure, but
and that's
you
understandable.
also need to be, again, the goal is no seizures, no side effects. So you should never be told that you have to settle for side effects in order to have seizure control. You should be able to have, good seizure control and fewer side effects. So you should always be working together towards that goal. You may not reach it entirely, but you need to have a neurologist who is willing to work with you to get closer to that goal of no seizures, no side effects. And if you don't feel like you're getting that level of help or attention, then you can you're very lucky to be in a state where we have 7 or 8 comprehensive epilepsy programs and a lot of epileptologists. So there are a lot of different options, and sometimes it can't hurt just to try something new and get a fresh new approach. So again, the bottom line is not to settle for your current situation if you're if it's preventing you from doing the things that you want to do.
I would agree wholehearedly.
Okay. All right,
I have
Dr.
a question.
Malone, I want to give you the opportunity.
There's another lady that wants a question.
Oh, sorry. Do you have time, Dr. Malone, for one more quick question?
Oh, yeah.
Okay.
That's fine.
Yep, go ahead.
Well, this has happened to me more than once, but the last time it happened, I don't know, maybe 2-3 weeks ago, I'm guessing. Anyway, whatever it is, I guess the best way I can describe it is I blank out. And as far as I know, I've never fallen or hurt myself in any of these, but I'll just, well, the best way I can describe it is one time the phone rang, and the phone has the one with the answering machine is in my room, and I woke up as the phone rang. I heard it ring. My friend answered in another room because we have more than one phone. Then later she said that this person we know as Mr. Sully had come on and left a message and said something really funny or something. I think I blanked out. I don't even remember hearing him. And she played it back, so yes, I did hear it then. And then the second time, this is the only one I'll mention unless you want me to say more. But I was playing, I had this game on my computer that goes from one step to another. And I was playing it. Then I guess I went off from the computer for a while, and I don't remember it, but I came back, and I was playing it again from one step to the other. Then I thought, this looks familiar. There's a way I can tell by looking on the screen if I'm on, I've gone off it and then come back on it and started it again. It's kind of hard to describe. Anyway, I saw that I had started it again and gone from game 1 to 40 or something, and I don't remember I did not and still don't remember having done it at all, until I saw that. And what my question is, someone was suggesting that I can keep track of it. I could write down the seizure, yes, but what could have happened before that, what I was doing. I have no idea what I was doing before. Either one, that could have possibly brought on a seizure, because I don't drink caffeine and I can't think of anything else except maybe stress and stuff that could have caused it. And for the most part, I'm not under stress in my life, thank God. Any suggestions on how I can keep track of something like that as to what happened before it?
Well, first of all, one thing I wanted to say is that with epilepsy, we've talked a lot about triggers, and keeping track of your triggers is really important, but it's also important to realize that epilepsy is, by its nature, unpredictable, and sometimes you can just have a seizure, and there's no obvious trigger, it just happens. And so sometimes you can, spend a lot of time trying to figure out what was the seizure, what caused this, and sometimes it just happens. So, but as far as how do you deal with the fact that sometimes, or Dr. Malone, how do you deal with issues of not remembering periods of time and determining whether that's because you have memory problems or whether that's because you maybe had a seizure?
And, with those situations, what I would do is definitely, document them to be sure we know how often they're happening. Yeah. But when I have patients that have periods of confusion, I'm always concerned that there are seizures that are occurring that we may not be aware of. And in those cases, I monitor those patients. So,
excuse me, pardon. My phone just keeps crackling. I'm sorry, I can't hardly hear you sometimes. You said something about document.
Oh, basically, just the occurrence, the fact that they're happening. You mentioned you had one on one day and another on a different day. Keeping track of those.
On the same day.
Oh, they both happen on the same day. Okay.
Yep.
And as Russ mentioned, there may not be a trigger. It may just be that you had a seizure that day and you didn't get a warning, you didn't have a trigger, it just happened because they can be unpredictable. But what we can do to help investigate that, if you're having episodes of confusion or time lost, those are indicators that there could be seizures happening, and we want to investigate with EEG to see if there are things going on that you're not aware of. That's really the only way for us to know what's truly seizure and what's not, because, again, I don't have an explanation for these episodes that you've been having, so that sort of be my recommendation, is that we investigate that a bit further with EEG monitoring and see what's going on.
And I did have tests, might have been AEG or something, and the doctor said everything was okay, but then that was some days after that had happened. It wasn't like I had the EEG the same day or the next day.
Right, and in between seizures, even in patients with epilepsy, you can have a normal EEG. It's really a matter of capturing more brain activity and then also the specific event. So if we could actually get what you're experiencing captured on EEG, we can see what your brain's doing when you have that episode. And that'll help us decide what the best management would be for you.
You mean even if I had the EEG, say, like a few days later, it would still pick up something that, because of that seizure or whatever?
It may or it may not. So after the events actually happen, you may or may not have a normal EEG. What I'm saying is, depending on the frequency and how these occur, we may be able to do investigations and actually capture one on EEG.
Stupid phone, pardon?
We might be able to capture one on EEG and see what it is. Basically, it's a chance. It depends on how often they're happening. If they're happening frequently enough for us to do that, then we can give you more information. If they happen and we can't capture it, we don't see anything on EEG, we have to start making some assumptions based upon whatever else we discuss about the details. Does it sound like seizure, does it not? We're making an educated guess only because we can't get the information documented. To have a definitive answer is always better, but in absence of that, then we want to make our best guess to try to figure out what's going on, what does it sound like it could be, and what do we think will help.
Okay, that's good to know. How can I tell if I have it? Because sometimes, I can't find something or something will happen. I think, I don't remember that. Now, I don't know if that automatically means I had that type of seizure, whatever it was, or, I just don't remember. No one remembers everything.
Exactly. And in situations like that, again, the EEG helps us to differentiate between what could be ongoing seizures that you're not aware of versus things that may just be normal. So we need more information is my point.
Okay, great. Thank you.
Yeah, no problem.
Okay, well, we've kept you long enough, so I want to give you a chance to get back to your job and everything. So thank you so much for your time and for sharing all of your expertise, and thank you everyone else for participating and for sharing your experiences. And hopefully you guys all learned something new, and the next Learn and Share call is on August 5th, and the topic is epilepsy in adolescents. So, all right, thank you, everyone.
Thank you.
Russ. Take care, guys.
Thank you.
Bye-bye.